would be to see more about pain management. So this is what the course outline looks like. By way of introduction, pain is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or pain or potential tissue damage. The inability to communicate pain does not mean that an individual does not feel pain. That means despite the fact that animals cannot communicate verbally to say that they have pain, they can actually experience pain, or they actually experience pain. So causes of pain: trauma can cause pain, surgery can, medical problems, infectious and inflammatory diseases, chronic diseases can all be causes of pain to our animal patients. So how do we classify pain? According to severity, it could be mild, moderate, severe. According to the duration, you can have acute pain, like cervical pain, which is most times treated satisfactorily with analgesics. It can be chronic pain. Many times chronic pain may take time to address. Referred pain and neuropathic pain. So why is it important to treat pain? Well, pain causes patient suffering, which is stressful for owners and caregivers. If a patient has had surgery, pain promotes inflammation and that will delay wound healing. Pain also suppresses the immune response, predisposing to infection and increasing hospitalization time and cost. And if a patient is under anesthesia and pain is not adequately addressed, higher doses of anesthetic drugs are required. And that will make the anesthetic episode more dangerous, so to speak, or the possibility of having adverse effects higher when the animal is feeling pain and you have to increase the anesthetic drugs usage. So when you take your analgesia during surgery, use less of the anesthetic agents, and that is safer for the patient. There are some myths about pain, and that is animals don't feel pain, but that they feel pain less than humans. Sometimes I've heard people say that pain is beneficial for rest, healing, and recovery. That is not true. We have said that the fact that our patients cannot communicate their pain does not mean that they can't experience pain. And when they experience it, we should help them to alleviate it. We should find other means of allowing them to rest the painful sites rather than depriving them of analgesia. Then there are some foods that animals tolerate pain better than humans. They are all myths. Because if we look at the pain pathway, it is similar to that in man. And many times when one thing there's pain and analgesics are given, if truly there's pain, the analgesics will take care of the pain and the pain goes away. So all the pain behavior seen will be reversed. And that shows that animals do feel pain and analgesia is important in them. And patients do feel pain. Sorry, the network had issues. Let me go back to my screen. Can you still see my slides? Dr. Fadigwe, can you confirm if you can still see my slides? Hello? Hello?
Hello, we can hear you, madam.
Okay, I don't know where I got to where the network field. Can you still see my slides? Okay, can you see my slides? Can you see the screen?
No, we can't.
We can't see the screen, but we can hear you loud and clear. We can't see you. We can't see the slides.
Okay, I will see what to do. Sure. Can you see my screen now? Can you see my screen now? Hello, Dr. Fadigwe. Can everyone see my screen now?
No, ma, we can't see your screen.
You still can't see it. Can you see the screen now? Hello?
The screen is trying to come up.
Okay. Is it up now?
We can see you. We can't see the screen. We can't see the slides.
Not yet. It's yet to come up, but it's trying to come up. Once we see it, we'll let you know.
Okay.
Thank you, ma'am.
Can you see it now? Can you see the screen now?
Not yet, ma'am.
The network seems to be the issue because I've shared it. Okay, let me share one more time and see if we can get it. Can we see it now?
No, ma.
It's actually trying to come up. The space is there, but the slide is not yet appearing there.
Okay.
So maybe just give it some few seconds. Maybe it will appear then.
Okay.
has still not appeared yet.
Okay.
Aha, it has come.
Okay.
It has come.
Okay, good. Is it still there?
It's there.
Okay, okay, great. Is this where we got before? Where we got to before?
No, it's starting from the beginning.
It's starting from the beginning. Wow.
Okay, no, pain assessment and behavioral changes is where it is now.
Okay. Okay, let me just go back one slide, then we'll continue. So I said pain has consequences if not treated. So pain can cause patient suffering, which is stressful for both the owners and the caregivers, apart from the patient itself. Pain promotes inflammation, which delays wound healing. Pain suppresses the immune response and predisposes to infection and can increase hospitalization time and cost. Anesthetic risk is also increased if pain is not adequately addressed during anesthesia, because higher doses of the anesthetic drugs will be needed to maintain a stable plane of anesthesia. So that can make the procedure less safe for the patients and there could be threats of adverse effects. But if pain is adequately taken care of, then one needs less anesthetic to make the animal maintain the stable plane of anesthesia. So I already told us this myth about pain. I don't think I should go back to them again. I told us that the pain pathway in animals is the same as in man. So they are experiencing pain the way animals, the way humans do. So how do we assess pain? I said we can use behavioral changes, we can use physiological changes. For behavioral changes, we can have vocalization, which can be spontaneous in response to movements or palpation of the painful area. The facial expression can be a pointer to pain, dull eyes, dilated pupils, drooping head and ears, pinned back with all the facial expressions showing that an animal is in pain. Self-awareness. The animal may attempt to lick, bite, or scratch the painful area. And in cases of severe pain, there could be self-mutilation. The animal may change its body position frequently. There could be overall reduced activity, stop sleep patterns, decreased appetite, and so on. And attitude. The animal may become more aggressive. An animal with an otherwise good temperament may become aggressive because it's in pain. The animal may become more withdrawn, anxious, comfort-seeking. The grooming, the hair coats will not look as shining, as good as it was when the animal was not feeling pain. You can have swelling from feces and urine, which the animal will not take care of because it's in pain. The animal may guard the painful area, can have hunching, the animal may fall and roll on itself, especially in abdominal pain. Then if an animal is painful on the limbs, there could be lameness, there could be seated gait, stiffness, and reluctance to move. So I just have some pictures showing pain behavior, like attitude. This dog attempted to bite in response to manipulation of the pelvis out of pain. Without of consciousness, this patient is looking at the site of pain. This is the horse pain from sand colic. Eventually, we diagnose it for sand colic kind. That is the horse. This is another dog in pain. This is the dog raising its limb as a result of pain. This is also a pain behavior. This dog is expressing otitis media. It's tilting its head. The cat, which you can see the eyes bright, is non-painful, while the other cat is painful post-surgery. This is another cat. and as its head down, it's looking dull. It has just had respiratory laparotomy and the pain has not been adequately taken care of. This is a cat switching abdominal pain. Pambitra can cause abdominal pain in patients. It's especially more painful in dogs than cats. It's sort of facial expression. This is a cat with dilated pupils. Expressive pain following ovarysterectomy. Then I put this there first to see what severe pain can cause. This lioness mutilated its tail because of pain. We had to duct the tail at that level, and this is the duct tail after the procedure. This is the same lion looking happy. So I said pain can also be assessed using physiological signs. You can see twitching, tremors, convulsions, sluggish reflexes, paralysis, numbness, dilated pupils of the part before. The cardiovascular system too and respiratory system can be pointers to pain. You can have increased heart rate, hypertension, a severe shock can have pain. A patient feeling pain can have tachypnea, increased respiratory rate. And these are also other physiological signs of pain, increased circulating levels of adrenocorticotropic hormone, catecholamines, beta endorphins, can have increased blood glucose, lactic acid, free fatty acids. Then there's something called, you can also score pain to assess how much pain a patient is experiencing. So what are the clinical uses of pain scores? That aids to diagnosis of pain, they help to determine pain intensity, the quality and duration, and they also help to guide the choice of therapy. And they can assist in evaluating the effectiveness of therapies. When we administer analgesics, we can evaluate, we can score the pain to evaluate how well or how effective the analgesics we have administered are. So as part of pain scoring, we have preemptive scoring system. You can assess pain even before it occurs, judging by the type of tissue damage or whatever. You can know what kind of pain the patient is experiencing. The AR pain scales, visual analog scale, simple descriptive scale that can say whether pain is no pain, moderate pain, or severe. There are numerical rating scales that you can use in assessing scale. Maybe the worst scale 10, the score 10, followed by 9, like that till 1, to assess how much pain the patient is feeling. There are some more sophisticated pain scales, the Glasgow Composite Pain Scale. Some universities have the pain scales they use that's already validated. When you come for the on-site training, we can show you many of this. And I already mentioned this. So physiological parameters are good pointers to pain. Increase in heart rate, respiratory rate, blood pressure, especially when the patient is under surgery, indicators of pain. So there are some general principles about pain management, irrespective of the type of pain. Timing of analgesia. This is especially pertinent to surgeries. If you give what is called preemptive analgesia, that is administering the analgesic drugs even before the pain occurs, even before the tissue damage that will cause pain occurs, it helps very well in achieving good analgesia and treating the pain eventually. So this is it. I said prevent pain using preparative analgesia where possible if you are talking of analgesia. Where pain is already established, treat as early as possible. And we should use adequate analgesic doses and dosing intervals to prevent pain breakthroughs. Many of the drugs we use, they have their duration of action. So if the analgesic you are giving, the duration of action is 4 hours, that means in another 4 hours one should give. If one waits for longer, the animal may have started experiencing pain before we give the next dose, which is not good. Then there's something called multimodal analgesia. This provides the most effective pain relief and avoid gaps. It's just the use of different classes of analgesics together to interrupt the pain pathway at multiple points. And this causes synergistic effects and produces profound analgesia. When you interrupt the pain pathway at different levels, you are able to achieve better analgesia. I showed us, I will go back to it again, the pain pathway. Different analgesics, I think I will send that to you later. Some of the analgesic drugs and the points at which they interrupt pain. This is perception, this is the pain pathway, like I said, perception of the pain, modulation, transmission, transduction. So when you use multimodal analgesia, it means you are using drugs that work on different parts in the pathway, and that achieves better analgesia than using individual drugs. Apart from better analgesia, it also helps to reduce the quantity of each drug you use, and that makes your analgesia even safer for the patient because there are really no safe drugs. So the lower you use, if possible, to use them in a way that to still achieve your goal. So when you use different classes of analgesics together to interrupt the pain pathway at multiple points, you have a synergistic effect and you have profound analgesia. For example, the combination of opioids and non-steroidal anti-inflammatory drugs is very good for traumatic pain or post-operative pain management. The way you combine local anesthetics with your pain protocols, you achieve better analgesia and a pain-free animal. Then as the level of pain decreases, one other place we should notice is that you can add more types of analgesics. Then I told you about those myths before. So there's something called principle of analogy, and that is that you should treat pain even if its presence is not obvious. Assume that a stimulus causing pain in man can also cause pain in animals and provide analgesia. Then match the dose and duration of analgesic treatment to the anticipated level and duration of pain. I told the operative scale scoring the other time. If you can anticipate the level of pain expected from a procedure, expected from the disease, and it can help you to match the dose and duration of your analgesic to achieve analgesia in such scenarios. Then analgesics can be used as a tool to diagnose the presence of pain. If you see what you think is a painful behavior, if you administer analgesics, the pain will go, and that can help you to diagnose that well, what you saw was actually pain. Another thing we should have in mind when treating pain is that we should tailor pain treatment to each individual. We should take an individual approach. We shouldn't have a straight jacket that every patient that comes in, these are the drugs, combinations, and dosages you are going to use. You assess the patient's pain, a particular patient, and treat accordingly. So individuals have varying analgesic needs and responses to drugs. So we assess patients at regular intervals to ensure that adequate pain relief is being provided, and even for adequate duration of time. So I already mentioned this, I'm just mentioning them again. There's a term called preventive analgesia, just administration of analgesic before tissue injury. I already said that most times you employ that for anesthesia. You give during surgery, So you give analgesics in the preoperative period, even before you make your incision. So even before the injury occurs, you are administered analgesic. And there's something called preventive analgesia. This is the administration of analgesics before surgery, during surgery, and postoperatively. This considers factors in all perioperative movements that can contribute to peripheral and central sensitization and involve, it considers factors in all perioperative movements that can contribute to peripheral and central sensitization and involves any perioperative analgesic techniques or drugs for pain relief. This also refers majorly to surgery, and that is by taking care of pain at every stage. Before the procedure begins, you have administered an analgesic. While the operation is on, you are administering analgesics, and after the procedure is done, you administer analgesics. When you have discharged the patient and you know that the pain period is still on, for example, if you discharge the patient like a day after the procedure, you can give the client analgesics to administer to the patient at home. And I already told us about multimodal analgesia, which is the use of different analgesics that affect the pain pathway at different points. So preventive analgesia is a clinical approach, especially for surgical procedures. Then here are the classes of drugs that are used for pain management currently. You have the opioids, alpha-2 agonists, you have local anesthetics, you have non-steroidal anti-inflammatory drugs, and others include ketamine. You can use gabapentin for chronic pain. Non-steroidal anti-inflammatory drugs are also employed in the treatment of chronic pain. Ketamine can also be used for management of chronic pain. So I have examples of opioids here: tramadol, pentazocine, morphine, butorphanol, buprenorphine, pethidine, methadone, fentanyl, remifentanil, sufentanil, afentanil, oxymorphone, codeine. The list is longer than this. There are still some drugs that are not included here. But here in Nigeria, tramadol is readily available, pentazocine is readily available, so they can both be used to achieve analgesia in our patients. Morphine, we currently don't have access to it. It's highly controlled. Butorphanol, buprenorphine, most of these other ones, we don't have access to them in best practice in Nigeria, but tramadol and pentazocine are available. In fact, tramadol, as we all know, was over the counter until we started experiencing abuse from it. So, but one can still get them with one's prescription. So opioids are the first option for acute pain management. The epidural morphine can produce analgesia for up to 24 hours, although we don't have it. But opioids can cause bradycardia, they can cause respiratory depression. Tramadol causes less of that. So both tramadol and pentazocine, we can use to achieve analgesia. Alpha-2 agonists have good analgesic properties. Examples include acomon-xylazine, medetomidine, dexmedetomidine, bromifene. Xylazine is available, so we cannot make use of it. Although alpha-2 agonists are best used in elderly patients because of the cardiopulmonary depression they are used for, especially bradycardia. Can have bradycardia with the use of xylazine. So when you are administering the alpha-2 agonist, administer to patients that are elderly. Local anesthetics superb analgesia. They provide excellent analgesia. We have lidocaine, mepivacaine. I think mepivacaine is available, but the most commonly used, the ones we use most commonly in West medicine and even in Nigeria is lidocaine and mepivacaine. They are readily available. They can be used with various local anesthetic techniques. We can use them to achieve various local anesthetic techniques to achieve analgesia for our patients. Epidural anesthesia, for example, will provide epidural administration of a local anesthetic. We provide analgesia from the umbilicus down. So any affectation from the umbilicus downwards, the perineum and every area there, epidural administration of a local anesthetic can take care of it. And it is not only local anesthetics that can be introduced into the epidural space. Even opioids can be administered to the epidural space. I told you of epidural morphine when we were talking about opioids, I said epidural morphine can produce an analgesia for up to 24 hours. We have attempted giving both tramadol and pentazocine in the epidural space, and they have achieved relatively good analgesia. So since we have them here, we can use them. Then I noted here that local anesthetics are good adjuncts to general anesthesia. They provide excellent analgesia when applicable. Medical personal block abdominals may not be applicable many times for bacterial cases. I thought of non-steroidal anti-inflammatory drugs. This is another class of drugs that can provide analgesia. We have many examples to diclofenac, piroxicam, paracetamol, dapirone, etodolac, phenylbutazone, flunarizine, ibuprofen, ketoprofen, ketorolac, naproxen, tepozolin, ibuprofen, and many other ones. But when you are administering non-steroidal anti-inflammatory drugs, it's important that you don't administer to patients with renal or hepatic diseases, diabetic patients, hypertensive patients, patients that have coagulopathies, or patients that are on another non-steroidal anti-inflammatory drug or corticosteroid. So you should choose the non-steroidal anti-inflammatory drugs carefully. You should choose the patient will use them for carefully. So one challenge or one fear of the use of non-steroidal anti-inflammatory drugs is toxicity. But if you choose your patients carefully, they can be safely used and they also achieve good analgesia. Meloxicam, ibuprofen, and etodolac have high safety margins in dogs, whereas a drug like ibuprofen has low safety margin. You shouldn't give more than 3 days if you are giving to the dog, and just once a day. And you are even on the lookout to see if there are no signs of toxicity. Because meloxicam, ibuprofen, etodolac, they have high safety margins. Diclofenac is readily available. Piroxicam is available. Paracetamol is available. Dapirone is available. So meloxicam is available. So we have enough analgesics to provide analgesia for our patients. I've said this earlier that non-steroidal anti-inflammatory drugs combined with opioids provide excellent analgesia for trauma and also for post-operative pain management. This is an example of multimodal analgesia therapy. So other drugs that can be used to achieve analgesia include ketamine. I'm sure that many of us know ketamine as an anesthetic agent. When it's combined with xylazine, in this part of the world, we use it for lots of surgical procedures. So both ketamine and xylazine have an analgesic property. But ketamine alone in sub-anesthetic doses can be used to achieve analgesia. Many times it's used as constant rate infusion intraoperatively to provide analgesia to patients. I told us that gabapentin is a useful drug for management of chronic pain. Then I have some nursing considerations, although this will not be applicable to you in theory, but you have the patients coming into you sometime for the first thing before referring to surgery. So immobilization of soft tissues and orthopedic injuries, just like applying splints for a patient with a little fracture or applying a robot joint can assist in alleviating pain in such a patient. Adequate bedding and the warm environment, emptying the urinary bladder, this applies also more to patients under surgery, can assist with pain alleviation. Physical therapy like massage, cold and warm compresses can achieve analgesia. Effective nutritional support will make healing faster and can also help in achieving analgesia. So tender loving care, treating the animal with a lot of kindness, support, talking to them, and help in ameliorating their pain somewhat. Then I gave some dosages. Under with some like them giving some here. So I put the dosages of some analgesics here. I have a material that has more dosages that I would send to the class later. So pentazocine about most times we use 2 milligram per kg IM in drugs. Tramadol for both dogs and cats, you can use 2 to 4 milligram per kg. Tramadol can be used in both to use this successfully for pain management in ruminants. Alpha to agonist. This dosage for alpha to agonist is in dogs 0.5 milligrams to 2 milligrams per kg. In ruminants, you use less. I'm sure we all remember that. The dosage of xylazine in ruminants is 0.05 to 0.1 milligram per kg. If you are giving IV, I would rather use the lower dose. In fact, that is the standard London. When giving drugs, IV, at least anesthetic drugs, you give about half of what you give as IV. So if you have any cause to give xylazine to report, IV is 0.05 per kg. IV, you can give 0.05 to 0.1 milligram per kg. Local anesthetics like Anakin and Bupivacaine, I've already mentioned them. In anesthesia care, many times we need a local anesthetic to achieve epidural anesthesia for whatever painful condition or reason. We usually combine lidocaine and bupivacaine. Our reason for doing that is that lidocaine has a short onset of action, but a short duration of action. While bupivacaine, on the contrary, has a long onset of action. Bupivacaine, the toxic effect of about 30 minutes, but it has a longer duration of action. So sometimes we combine them together to achieve a faster onset of action than bupivacaine would achieve in humans, and a longer onset of action than lidocaine alone would give us. But if you are looking for duration of action alone, if you want a longer duration of action, the bupivacaine would be better place to achieve analgesia. Then when you give a local anesthetic agents like lidocaine, bupivacaine in the epidural space, when you give them epidural, you can have temporary paralysis of the hind legs. The animal would go down, not able to support itself on the hind legs. But when you give opioids, I already told us that opioids can be given into the epidural space. If you give an opioid like tramadol, the animal would have, there will be analgesia without the animal being recumbent. So to achieve analgesia using the epidural route, if you want analgesia, you will use an opioid rather than a local anesthetic. But if you have no problem with the animal being recumbent, they can use the local anesthetic agents like lidocaine and bupivacaine. This is an example of carprofen 2 milligram per kg BID in dogs, or 4 milligram per kg once per house or subcute. This is another analgesia, another non-steroidal anti-inflammatory. Daracoxib can be given at this dosage 3 to 4 milligram per kg once per house for 7 days. These are some of the drugs you can give a patient, a client to take home to administer to the patient. We have ketoprofen too. Paracetamol of course, we all know that paracetamol should not be given to cats. So 10 to 20 milligram per kg per horse. If one is given IV, the lower dose should be used. I already told us that ketamine can also be used to achieve analgesia in subanesthetic doses. I mean, lower doses, much lower doses than what we use for analgesia. Sorry, much lower doses than we use for anesthesia. When you give the anesthetic dose, it causes the animal to sleep. But in very low doses, you can achieve analgesia alone without the animal becoming unconscious. These are some other analgesics. Meloxicam, I told you meloxicam is available in Nigeria, so we can use it for our patients. Phenylbutazone, I'm not sure if it's available, but I'm sure meloxicam is available. So we can give a loading dose. That means to start, we can give 0.2 milligram per kg in dose. Then we can make it lower as you score the pain and the pain comes, you can reduce the dosage. So this case scenario as well is more applicable to surgery. I told us that this is a class of drug used for sedation or as a pre-medicant. It has an analgesic property. So when one is using the phenylbutazone, like acepromazine or chlorpromazine, we combine with opioids to achieve preemptive analgesia. I already told us that intraoperative analgesics help reduce the amount of general anesthetics and provide safer anesthesia. Also, if a patient is under surgery, you have to monitor for signs of pain so that you'll be able to provide analgesics as appropriate. I already told us this is like a summary that local anesthetic techniques, exogenous general anesthesia provides excellent analgesia. And many of the anesthetic techniques, we can use them to achieve analgesia even in non-surgical patients. So if you have done a surgery for a patient, always plan for post-operative pain management, assess pain and therapy. And if you are doing analgesics, not because of surgery, but for some other painful conditions, you still need to assess the pain to monitor your therapy. We already said that. That puts here whereby we can anticipate the level of pain. Superficial lacerations, when you have chest pain, when you do castration, you come with mild to moderate pain. Palmitra in dogs causes moderate pain. Varicectomy can cause moderate pain. Dystocia can cause moderate to severe pain. So a patient for dystocia, you must always have it in mind to use analgesic and take care of the patient even before you do the surgery or manipulations to assist in getting the fetus. You know, we do a lot of, hey, can we still quick and mind? So for dystocia, for example, in goats, sometimes you manipulate in cattle too, so you can give analgesic to the patient before doing that. So central nervous system infarctions, tumors, they are associated with severe to excruciating pain. Well, you would not be dealing with fracture. Many times we refer to the surgeons, to the orthopedic surgeons. Fracture repair cause severe to excruciating pain. Bone injuries can cause severe to excruciating pain. Limb amputations, not necessarily applicable to humans. They are good to know as veterinarians. So, mild, moderate, severe pain, one tries to tailor the analgesic provision to the severity of the pain. So, some tests are suggested. I will send this to you so that you can look at them. The excellent materials on pain management in dogs, recognition, assessment, and management of pain in our patients. This is a text that you can get. These are some articles. This is by myself and Professor Yarife. And this is another journal article by a human anesthetist. In Nigeria, Professor Sheyomu, who's trying anesthetist outside this country. It's also a good material. So we have come to the end of the class. As I said, I would get some materials across to us to use. Then when we go on site for that part of our training, we see some pain management in animals where we do them in the way they are done in those centers they would assist us a lot in giving better analgesia to our patients. Then you'd also be holding seminars, as they are called, and I can give you term papers, give you topics to submit as term papers. So we have come to the end of the lecture, and oh no, I missed the slide here. So if there's anyone that has any question or query, let me see your hand so that you can unmute, and let's see if the echo will be there. If there's an echo, then we need to send our queries to me personally for me to attend to. And at any time, you can call me to ask questions, to rub minds together, to discuss your cases. I would always be available to speak with us. So do we have anyone that has any question to ask? Anybody?
Thank you very much. I think those who have questions can raise their hand.
Okay, Dr. Tuba, let Dr. Fadikwe finish talking, then you can ask your question. Yes, Dr. Fadikwe.
Okay, ma, I was saying that those who have questions will have raised their hand using the icon so that you can recognize them.
Tuba, yes, Dr. Tuba raises hand. Dr. Tuba, please unmute yourself and talk. Dr. Tuba, Dr. Tuba. Dr. Tuba, unmute yourself and talk. Unmute yourself, Dr. Tuba. If you don't unmute yourself, don't hear you. Hello. Hello.
Hello.
Okay. Yes, I can hear you.
Yes.
With the speaker, there's a lot of echo.
And the network during if you can send lectures for us.
Dr. Tuba, who is talking? I can hardly hear you. So I would suggest that I can hardly hear you.
No, ma.
So,
Are you here?
okay, yes.
Yes. The lectures so intense. Long, and then you tend to run through that we just see how we can forward to you for.
Dr. Kabir, the son of Dr. Ibrahim, I think what you should do, Dr. Fadikwe has my contact. Dr. Fadikwe.
Okay.
Has my contact. So get it from him and you can send me a WhatsApp message to address your questions. Because the network, there's a lot of help I cannot hear you. Dr. Tuba's hand is raised. Dr. Brown, can you mute your mic? Let's see if you can hear Dr. Tuba. Dr. Tuba.
Hello, ma'am.
You can unmute. Hello. Hello, yes, Dr. Tuba. Hello. Hello. I think it's best if you send our questions privately. So there's a lot of echo and we can't say.
That's very true. You are not the only one. Even we cannot hear him.
Okay. So let's end the lecture here. Everyone can send their email addresses to Dr. Fadipe to send to me, or you collect my number from him. I can send materials to WhatsApp. So you can get the materials I have. And if I have any other assignment for you too, I can give you. So I wish you all a good afternoon and a happy weekend.
Thank you very much.
You're welcome. So bye everyone.
Thank you very much, ma'am. So our teacher don't go, so make una send una email address to me. Make I forward them to them. So nice weekend.